And welcome to Deuk Spine Institute. I'm Dr. Deuk Majan. I'm here with my team. Our patient comes to us from Georgia. He has many problems, and they're all related to the lower back and back pain. We've already fixed his discs. He doesn't have disc problems anymore. He's got facet problems. He has facet joint arthritis and pain. He has sacroiliac joint pain. He also has piriformis syndrome, but not now. It's gone away temporarily on its own. So today we're going to be fixing his facet joints. We're going to be treating the SI joint. The way we do this is we're going to do the Deuk plasma rhizotomy. We're going to go in and permanently deaden the pain nerves to the joints. We're going to start with the Deuk plasma rhizotomy of the facets, bilateral L3-4, L4-5, L5-S1. We'll be treating 6 facet joints and 8 nerves. All right, let's get started. I'm going to make an incision. And the incision is 4 millimeters. And through that 4 millimeter incision, I'm going to go in with a probe. We call it the Deuk Spine Plasma Wand. And we're going to generate some plasma. What is plasma? Well, plasma is basically vaporized material. It's material in a vapor form. Vapor is gas. If you remember Ghostbusters, you remember the plasma of the ghosts. And in this case, we don't have ghosts. We have electrons. Electrons are being energized so that they create plasma. Shot? All right. Our first target is L3. And you see where the tip of the probe is?
Yes, we do.
Just above it is where the pain nerve is, and that's the perfect spot. It's where the transverse process, show us that, Jordan, connects to the superior articular process right there. Show us the superior articular process. It goes up and down, and you find it just lateral to the pedicle, which is the circle, the owl's eye right there. So we're in perfect position for our first rhizotomy, and again we use a new technology called Deuk plasma rhizotomy. It's patented. I patented it, and it works really, really well. So this patient's here for this procedure. Shot, you got to make sure you're sitting on the bone, which I am, and a little jumpy. Burn death. Should I wait? I'm going to wait a minute, and then we'll get started. I can also try to give a little bit more numbing medicine deeper inside. But that said, our goal here, folks, is to destroy nerves. That's what's odd about this procedure, is it's a destroy pain nerves procedure. We're trying to destroy the pain nerves. These are nerves that are known to transmit pain signals from injured joints like the facet joint up to the brain. They're called sensory nerves because they're responsible for sensing or feeling. Let me know when I can proceed. All right, Henry, let's show the audience. Shot. Let's show them our video on how the facet joints can be so painful.
Copy that.
You can see, Shot, from the video that facets can cause pain because they get arthritis in the facet joint itself. Shot? And that pain from the facet joint travels up to the brain, as you saw in the video, and it's interpreted as pain signals. Shot? All right, so that should be pretty good right there. I like that. As a matter of fact, I could feel the pain nerve with the tip of the probe. So that's good. Literally, I felt the pain nerve. And I just transected it. So I think that was the main one, to be honest. What I typically find doing these procedures is quite fascinating, something I never really knew before. But not all these pain nerves are the same caliber. They're not all the same. Some of them are thicker than others, and you can feel it as you're cutting it. The nerve is fatter, bigger, more developed. Wait, let me just see. I think I'm a little too south. There we are. Sometimes you can be tricked, so you got to make sure you're on the right spot. You don't want to end up in the wrong spot. It would make a very bad result. Shot. So I always feel around, and I use the x-ray to make that I'm on the right spot. There's the transverse process. I just kind of went out a little bit wider there. There's the TP. Wide. Shot. Let's see. But you really want to make sure you're in the right spot. This should be wide. I think it just keeps moving. Shot. Yep, that is wide. Good. And I want to come right along that TP and basically burn the pain nerve to the joint. Almost done with this side. We're going to go to the other side, the right side. So we started with the patient's left, and we're going to go to the right. I can feel the arthritis in that joint. It's pretty bad. That was the L5.
It looks arthritic too.
Yeah, it does look arthritic. You can see it's more arthritic than the other ones. Jordan, show us the arthritis while I navigate down to the next nerve. Yep, shot. All right, I'm heading down to the last nerve, which is where the white arrow is. Shot. And I've got to get my probe over there. Shot. Getting close, but no cigar yet. Any questions, Henry?
Yes, we have a question
Shot.
coming from Izod on YouTube.
Hi, Zod. Welcome back.
Asking, is it always the
Shot.
annular tear that causes discs to herniate, or even without tear, it happens too? And what are the causes of osteophyte? Is it again the annular
Shot.
tear, or some sort of calcium deficiency that bulges the vertebrae?
Yeah, so great questions, Izod. Shot. I don't remember the first question exactly. Shot.
First question asking, is it always the annular tear that causes disc to herniate, or even without tear, it happens too?
You must have an annular tear for the disc to herniate, period. Yeah, end of story. There is no way for a disc to herniate without the annular tear. You must have the annular tear. Must. There is no other way for a disc to herniate. Now you may read in the literature there is, but they're wrong. There is no other way. Okay. We're going to make an incision on the right side and go to the right side now. Again, the whole surgery is done with a 4mm incision. I'm going to show them to you at the end, but it's virtually bloodless surgery. We only lose maybe a drop or two of blood on each side. And the patient is asleep. I don't know if I answered all the questions. Shot?
The next question they asked was, what are the causes of osteophyte? Is it again the annular tear, or some sort of calcium deficiency that bulges the vertebrae?
Yeah, there's a few types of osteophytes. One of them is called a traction osteophyte. The other one is basically a calcium deposition where the herniation is. And The one that we take out, the one that can cause problems is the one that is the osteophyte where the herniation is. And that one is due to your body just depositing calcium. It's a little bit jumpy. Muscles are tightening up a little more than I want. Shot. On the other hand, a traction osteophyte, which happens at the end plates, usually at the back or front of the vertebral body, those, nobody really knows why they happen. I don't know why. Not going to pretend to know, but they never cause symptoms. We never treat them. We only treat the osteophytes that are by the disc, where the nerve root is. Yeah, those are the only ones I would treat. Not bad, huh, Jordan? Again.
I have a question.
Yeah, Dr. Berndes has a question.
Facet joint arthropathy.
Yes. Shot?
What is the main cause of that? Is it disc alteration and disc disease, or is it
No.
wear and tear? Like,
Yeah, the facet joint, Dr. Berndes' question is, what causes the facet joint arthropathy? It's basically an injury to the facet joint a long time ago where you tear the capsule and the joint becomes unstable. Now the bones can move in ways they're not supposed to move because the capsule used to hold them close to each other, so they only moved a little bit. Now they move a lot, and they create additional trauma by banging on each other now because they're unstable. And then over time, your body responds to that instability by hypertrophy, and you get all this inflammation around the capsule, and that inflammation gets scar tissue and calcification. So you get all the little crumbly, cottage cheesy calcium around, but the enlargement of the actual facet is your body's attempt to stabilize the joint through hypertrophy of the bone. So it's a combination. Yeah. You get sclerosis and hypertrophy, enlargement of the facet because of instability. You get the calcification of the capsule from inflammation of the capsule, which is due to the tear of the capsule that's trying to heal, trying to repair, but it can't. Okay? Good question. I think we're done here, right? At this one. Shot? Yeah. Shot? Maybe just a little more.
You okay for you?
Oh, yeah.
Sam, what time is it? 13:10.
We have another question coming from Tracy on Facebook, asking what spinal exiting nerves might lead to pain in the interior of the thigh.
Yeah, great question, Tracy. So Tracy's asking which nerves could lead to pain in front of your thigh. The answer is L2, L3, even L4 sometimes, but it's usually L2, L3. But pain in the front of the thigh is usually not due to a pinched nerve, Tracy. It's usually due to other conditions. The most common condition causing anterior thigh pain is a hip joint problem. If you have arthritis in your hip, or more importantly, a labral tear of the hip would cause some anterior thigh pain. So hip issues are the number one reason for anterior thigh pain. And then after hip, you have lateral femoral cutaneous nerve called neuralgia paresthetica, also causing anterior thigh pain. Very common, and that's an entrapment of the lateral femoral cutaneous nerve in the inguinal canal by the inguinal ligament, and it's most commonly in people who gain weight. They gain weight and they get some fat going, and that fat puts pressure on the inguinal canal. Almost done. We have one more medial branch to burn. Shot. On the right side for the facets, and then we're going to head over to the sacroiliac joints, but we'll end the broadcast. Any other questions? Ask them now, or
Yes.
forever hold your peace.
Next question from Izod once more on YouTube, asking what should be the state/condition when you advise ACDF instead of PLDD in treating cervical stenosis?
I don't know what PLDD is.
I think they meant to say DLDR. I don't know.
Maybe he meant DLDR. I don't know. I would never recommend ACDF. Let's pull the fluoro out because we're done with this surgery. And you have anything to wipe? Let me show you guys what we've done, and then I'll answer the question. But I would never recommend ACDF on anybody that can have the DLDR. So the only time I recommend ACDF is when there's like a really short neck and fat neck where I can't get in and do the DLDR safely, where there's a risk of complication. Okay, so I'm going to show you guys. Can you all see this?
Yes, we can.
There's your incision. It's 4 millimeters. 4 millimeter. One on the right, one on the left. Now we're going to do his sacroiliac joints next. Okay? And we'll put a little staple here just because, you know, we'll keep that in overnight. He's from Georgia, and we want him to not have bleeding in his bed sheets. We have the SI. Yeah, come on in.